Imagine someone, maybe someone you know, just experiencing this profound unexplained fatigue and maybe gradual, steady weight loss.
Mm-hmm.
And then, really strikingly, a subtle but distinct darkening of their skin, maybe around the knuckles or gums. What on earth could be connecting all these things?
That sounds confusing.
Well, that's precisely what we're going to unpack today. Addison's disease.
Yeah.
Our mission for this deep dive is to take, well, a stack of detailed notes on this fascinating but kind of complex endocrine disorder.
Right.
And pull out the essential nuggets of knowledge so you can quickly grasp what's really going on.
And maybe to kick us off, let's just define it simply. Addison's disease is a chronic endocrine disorder.
Okay.
It's characterized by the insufficient production of crucial adrenal hormones. We're talking specifically cortisol, aldosterone, and sometimes androgens.
Right.
And it's because of a problem originating directly within the adrenal glands themselves. So this makes it a form of what we call primary adrenal insufficiency.
Okay, so we know what it is at a high level, primary adrenal insufficiency. But where does Addison's actually come from? I think what makes this condition particularly interesting is the surprising variety of its origins. It's not just one single thing causing it, is it?
That's absolutely right. The most common cause, and this accounts for a significant chunk, like 70 to 90% of cases in developed countries, is something called autoimmune adrenalitis.
Autoimmune, okay.
Yeah. This is where your body's own immune system, it mistakenly attacks and destroys the adrenal cortex. That's the outer part of the adrenal gland.
How does it do that?
It's through a process where its own immune cells, called lymphocytes, they kind of infiltrate and damage the tissue.
Wow. And what's truly fascinating, I think, is how Addison's often isn't just an isolated issue, right? It's frequently like a piece of a much larger autoimmune puzzle.
Exactly. It really points to the body's incredible interconnectedness.
So when we talk about these autoimmune causes, are we often seeing Addison's popping up alongside other conditions?
Yes, precisely. It's often part of what we call autoimmune polyendocrine syndromes, or APS.
APS?
Yeah, and that tells us the immune system might be sort of broadly targeting multiple endocrine glands. Like in APS-1, it's typically seen with chronic fungal infections, skin, mucous membranes, and issues with the parathyroid glands.
Okay.
Then there's APS-2, which links Addison's disease with other really common autoimmune conditions like autoimmune thyroid disease, Hashimoto's or Graves', and type 1 diabetes.
Right. So one autoimmune problem can signal others.
Exactly. The insight here is that one autoimmune problem often signals a predisposition for others. It's like a pattern.
Okay. Beyond autoimmunity, what else can trigger this? Are there other causes?
Oh, definitely. Infections can also be a culprit. Historically, tuberculosis was actually a really significant cause.
Right, like TB.
Yeah, it could lead to considerable damage. It's much rarer now in developed countries, thankfully. But we also see cases linked to various other fungal infections and certain infections associated with conditions like HIV.
And sometimes the cause can be quite sudden and, dramatic, right? Like hemorrhagic or ischemic causes. Bleeding.
Yes, those are indeed striking when they happen. A key example is Waterhouse-Friderichsen syndrome.
Okay, what's that?
That's where you have severe acute bleeding into both adrenal glands, often due to overwhelming bacterial sepsis, like meningococcal infection.
Wow, okay.
But it can also be linked to conditions where blood clots are widespread, or even certain anticoagulant therapies, or severe trauma.
So we've covered immune attacks, infections, acute bleeding. Are there other, maybe more insidious ways the adrenals can be impacted? Slower things.
Yes, absolutely. Infiltrative disorders can also lead to Addison's.
Infiltrative?
Yeah, these are conditions where abnormal substances kind of build up in or invade the adrenal glands. Things like amyloidosis, sarcoidosis, hemochromatosis.
Okay.
Or even metastatic cancer, often spreading from primary sites like lung or breast cancer.
Right.
And then, of course, there are genetic causes too. These can involve inherited issues with hormone production itself, or conditions where abnormal fats build up in the body, or even disorders affecting how the adrenal glands respond to signals from the brain, like ACTH resistance.
And finally, it's worth noting that even some medications can inadvertently cause it, right? Like you mentioned, ketoconazole and etomidate inhibit cortisol synthesis.
Exactly. They interfere with the production. And others, like rifampin, can actually increase how fast the body breaks down cortisol.
It's truly eye-opening how diverse the triggers can be, all ultimately leading to the same fundamental problem. The adrenals just aren't working properly.
Precisely. Adrenal insufficiency.
So we've explored the diverse origins, but what does this all mean for the body when the adrenal glands aren't doing their job? What are we actually seeing when the system starts to fail?
Right. This is where the puzzle pieces really come together physiologically. When that adrenal cortex is destroyed, it leads to a critical deficiency in, well, three main types of hormones. First, cortisol. That's a glucocorticoid. Its deficiency impairs the body's stress response. It can cause low blood sugar or hypoglycemia, and it leads to that profound fatigue we mentioned.
The fatigue, right.
Second, aldosterone. That's a mineralocorticoid. Losing that results in sodium loss, high potassium levels, hyperkalemia, and low blood pressure.
Okay. Sodium, potassium, blood pressure. Got it.
And third, androgens, like DHEA. In women, a deficiency here can lead to a loss of libido and reduced body hair, like pubic and axillary hair.
Right.
And crucially, this overall deficiency also leads to a loss of negative feedback to the pituitary gland up in your brain.
Ah, the control system.
Exactly. So the pituitary keeps pumping out ACTH, trying to stimulate the adrenals. These elevated ACTH levels then stimulate melanocytes, the cells that produce pigment.
And that's the hyperpigmentation connection.
That's it. That's what leads to that characteristic darkening you mentioned earlier. You'll often see it very clearly in specific areas: palmar creases, the inside of the mouth, the buccal mucosa.
Oh, inside the mouth too.
Yes, and on scars, nipples, elbows, knees, places where pigment is normally a bit higher anyway, or areas of friction.
And these deficiencies, they manifest as a range of chronic symptoms that can often be quite vague, can't they? Which must make diagnosis tricky sometimes.
Extremely tricky, especially early on.
So what are the most common chronic symptoms someone might experience?
Well, the big ones are that persistent fatigue, muscle weakness, unexplained weight loss, and just a lack of appetite, anorexia.
Okay.
Then linking back to those specific hormone deficiencies we talked about, you'll see the hyperpigmentation, the low blood pressure, often orthostatic, meaning it drops sharply when you stand up.
Right. Feeling dizzy upon standing.
Exactly. And along with that, often an intense craving for salt. That's the body trying to compensate for the aldosterone deficiency.
The salt craving. Makes sense.
Yeah. Gastrointestinal issues are also really common: nausea, vomiting, diarrhea. Low blood sugar, hypoglycemia, especially in children, can occur. Then there are muscle and joint aches, myalgia, arthralgia, and even psychiatric effects like depression, irritability, and what people often describe as brain fog, just difficulty concentrating.
Wow, quite a constellation of symptoms. Now, while those are chronic, it's absolutely crucial we highlight the critical life-threatening emergency known as an acute adrenal crisis.
Yeah.
What typically precipitates or triggers such a severe event?
This is incredibly important. An adrenal crisis can be triggered by various stressors. Think a significant infection, physical trauma like an accident, major surgery, or critically, the abrupt withdrawal of steroid medication in someone who's been taking it long term and whose own adrenal glands have become suppressed. You can't just stop steroids cold turkey.
Right, that's vital. And when someone goes into an adrenal crisis, the symptoms are incredibly severe, aren't they?
Oh, absolutely. We're talking profound low blood pressure that can rapidly lead to shock. Severe dehydration, intense vomiting, and abdominal pain that can be so severe it can actually mimic an acute surgical abdomen.
Really mimicking something like appendicitis.
Potentially, yeah. And the lab findings during a crisis will typically show very low sodium, very high potassium, low blood sugar, and often a fever, even if infection isn't the primary trigger.
And the outcome if it's not treated.
The dire consequence is very real: coma and death if untreated. This highlights the absolute urgency of recognition and immediate treatment. It's a true medical emergency.
Okay, so given how vague the chronic symptoms can be, but how dangerous the crisis is,
Right.
how do medical professionals go about unmasking this mystery? What initial clues do they look for in, say, lab findings that might raise suspicion?
It often starts with routine lab work, actually. You might see that low sodium hyponatremia and high potassium hyperkalemia, both big clues pointing towards aldosterone deficiency.
Right.
Low blood sugar, the hypoglycemia from cortisol deficiency, is also common. You might see elevated markers of kidney function like BUN and creatinine, but that's often just indicating significant dehydration rather than kidney failure itself. And occasionally, you might notice a mild elevation in calcium levels for reasons that aren't fully clear but are recognized. But really, the cornerstone of diagnosis is always hormonal testing.
Right. You need to measure the hormones themselves. What's the go-to hormonal test, the first step?
The first-line approach typically is to measure morning serum cortisol and ACTH levels simultaneously.
It's morning levels. Why morning?
Because cortisol levels naturally peak in the early morning for most people. So a low morning cortisol is particularly suggestive.
Okay.
And what's so insightful here is how these two hormone levels immediately tell us a story. If cortisol is low and ACTH is high, that strongly indicates primary adrenal insufficiency. The adrenals aren't responding, so the pituitary is shouting louder, sending out more ACTH. The problem is right there at the adrenal glands.
That makes perfect sense. So if those initial levels point towards Addison's, how do you confirm it definitively? Is there a confirmation test?
Yes, there is. To confirm, we perform what's called the ACTH stimulation test, sometimes called the cosintropin test.
Cosintropin.
That's the synthetic version of ACTH we use for the test. So what we do is measure a baseline cortisol level. Then we administer an injection of cosintropin.
Right.
And then we re-measure the cortisol level at 30 and usually 60 minutes afterwards.
Okay, so you're stimulating the adrenals directly.
Exactly. A normal response would be for the cortisol level to rise significantly, usually above a certain threshold, like 18 to 20 micrograms per deciliter.
But in Addison's?
But in someone with Addison's, the adrenal glands are damaged or destroyed, so they can't respond properly. The cortisol remains stubbornly low, even after the ACTH stimulation.
I see. So the test essentially asks the adrenal glands, can you do your job when prompted?
Precisely. And in Addison's, the answer is a resounding no. We also often check plasma renin activity, PRA, and aldosterone levels. High renin and low aldosterone further confirm that aldosterone deficiency is part of the picture, which is typical in primary adrenal insufficiency.
Okay. Beyond these core hormonal tests, what other tools might doctors use to maybe zero in on the cause or get more information?
Yeah, additional tests can definitely be helpful. For instance, we can look for specific adrenal autoantibodies in the blood, particularly antibodies against an enzyme called 21-hydroxylase.
Ah, for the autoimmune connection.
Exactly. These antibodies are often present in autoimmune Addison's. Imaging, like a CT scan of the abdomen, can also provide clues.
What might you see on a CT?
Well, in autoimmune cases, the adrenal glands might actually look small, atrophied, but in cases caused by infection or infiltrative diseases, they might appear enlarged.
Interesting. So the size gives clues to the cause.
Yeah.
And I suppose if an infection, especially tuberculosis, is suspected as the cause, then specific TB testing, like a PPD skin test or an interferon gamma release assay blood test, would also be important, right?
Absolutely critical in those situations to confirm or rule out TB.
Okay. So while it sounds like a really complex condition to diagnose and understand, there's a real sense of relief, I think, knowing that Addison's is, in fact, a treatable condition. So how is it managed long term?
Absolutely, it is treatable, and that's the crucial message. The mainstays are lifelong hormone replacement therapy, specifically replacing the missing glucocorticoids and mineralocorticoids.
Right, the cortisol and aldosterone.
Exactly. For glucocorticoids, hydrocortisone is typically the preferred choice. It's usually prescribed in divided doses, often mimicking the body's natural circadian rhythm, so maybe 10 to 20 milligrams in the morning and 5 to 10 milligrams in the late afternoon or evening.
To mimic the natural pattern.
Precisely. Prednisone is another option. It's longer acting, taken once daily. But crucially, patients need to learn the sick day rules.
Ah, yes, the sick day rules. Tell us about those.
This is vital. During times of illness, like a fever, infection, or significant physical stress like surgery, or even major emotional stress, the body naturally needs more cortisol.
Right.
So patients must learn to double or even triple their usual glucocorticoid dose during these times to prevent an adrenal crisis.
That sounds like a big responsibility.
It is. We also have to caution against overtreatment, though. Taking too much glucocorticoid long-term carries its own risks, like osteoporosis, weight gain, and increasing the risk of diabetes. It's a balancing act.
Right. And what about the mineralocorticoid, the aldosterone replacement?
For that, we use a medication called fludrocortisone, usually taken once daily. The dose, typically between 0.05 and 0.2 milligrams, needs to be carefully adjusted based on the person's blood pressure, their electrolyte levels, specifically sodium and potassium, and sometimes their plasma renin activity levels.
The monitoring is key there, too.
Constant monitoring, yes. And sometimes patients might also need to maintain a relatively high sodium diet to help manage their blood pressure and sodium levels.
Okay. And for women, you mentioned androgen deficiency earlier. Is there an option for androgen replacement, like with DHEA?
Yes. For women experiencing symptoms like low libido, fatigue, or reduced mood that aren't fully corrected by the other replacements, DHEA replacement, usually 25 to 50 milligrams per day, can be considered.
What's the goal there?
The goal with DHEA is really to try and improve those specific symptoms. Libido, mood, overall energy levels, addressing those particular aspects of hormone deficiency that can impact quality of life.
Now, you mentioned the adrenal crisis earlier as a life-threatening emergency. Let's just reiterate the paramount importance of managing that crisis. What are the immediate steps if someone presents in crisis?
Paramount is the right word. It is a true medical emergency requiring immediate action. The first steps involve administering intravenous, or 5E, hydrocortisone, usually a large initial dose, like 100 milligrams, followed by regular doses, maybe 50, 100 milligrams every 6 to 8 hours.
Straight into the vein, high dose.
Absolutely. 5E fluids are also critical, usually 0.9% saline or normal saline, given rapidly to combat dehydration and low blood pressure. If blood sugar is low, dextrose might be added to the fluids.
Right, fluids and sugar.
Correcting those electrolyte abnormalities, the low sodium, the high potassium, is vital. And simultaneously, you need to identify and start treating whatever the underlying precipitating cause is, like an infection, to actually stop the crisis.
Got it. Urgent, multifaceted approach. Now, patient education sounds absolutely critical for living successfully with this condition. Given the lifelong management, the sick day rules, how much does a patient really need to become their own expert? What does patient empowerment truly look like when living with Addison's?
It's absolutely central. Patients effectively become, in a way, their own daily endocrinologists. They have to learn to listen to their bodies and adjust their medication based on life stressors, big and small.
Wow.
This means thoroughly understanding those sick day rules isn't just helpful, it's non-negotiable. Wearing a medical alert bracelet or necklace that clearly states adrenal insufficiency needs hydrocortisone is essential.
So emergency responders know immediately.
Exactly. And always carrying an emergency hydrocortisone injection kit, usually a pre-filled syringe or vial and needle, and knowing how and when to use it. The power comes from knowing how to react proactively and having the tools readily available to prevent a minor stressor from escalating into a full-blown crisis.
So their active participation isn't just helpful.
It's life-saving, truly.
And what are the potential complications if the condition isn't well managed? Or perhaps if overtreatment occurs over time?
Yeah, both under and overtreatment have risks. If the condition isn't well managed, the ever-present danger is, of course, that life-threatening adrenal crisis.
Right.
On the flip side, chronic overreplacement with glucocorticoids, even if trying to avoid crisis, can lead to long-term problems like osteoporosis, increased fracture risk, weight gain, high blood pressure, and diabetes.
Okay.
Patients with autoimmune Addison's are also at higher risk for developing other associated autoimmune conditions like thyroid disease, pernicious anemia, or vitiligo, so they need monitoring for those too. And there can be cardiovascular risks, either from the chronic low blood pressure associated with undertreatment or potentially from the metabolic effects of slight overreplacement over many years.
So it really is a delicate balance. But the good news, though, seems to be the prognosis, right?
Yeah.
With consistent lifelong hormone replacement.
Yes. The prognosis for individuals with Addison's disease who receive appropriate, consistent treatment is generally excellent. They can lead full, active lives.
That's great to hear.
The main mortality risk truly comes from an untreated or delayed treatment of an adrenal crisis, which again just emphasizes the critical importance of those patient education efforts we discussed, the medical alert ID and the emergency kit.
Absolutely. So as we wrap up our exploration of Addison's disease today, we've really taken quite a journey, haven't we? From understanding its, well, surprisingly diverse causes.
Autoimmune, infectious, genetic.
To seeing its profound impact on the body through hormone deficiencies, figuring out how it's diagnosed with those clear hormonal clues.
The ACTH stim test being key.
Right. And finally, learning how effectively it can be managed with careful, lifelong replacement therapy and patient empowerment. It really reinforces that what might initially seem like just a confusing collection of disparate symptoms can, with the right understanding and testing, be traced back to a specific and, importantly, treatable condition.
It really does. And I think this deep dive truly underscores how incredibly interconnected our bodily systems are, doesn't it? And how profound the impact of even a single gland's dysfunction, like the adrenals, can be on the entire person. It kind of makes you wonder, doesn't it, what other everyday symptoms that people experience might actually be subtle clues to a deeper, more systemic imbalance in the body, just waiting to be uncovered.
That is a powerful thought, a great reminder of the immense value of diagnostic clarity digging deeper and the really transformative impact that targeted medical intervention can have on chronic conditions, allowing people to regain control and live well.